Sometimes there is a patient that is no showing, canceling appointments, not following recommendations. So there's steps before the termination to document that noncompliance, because that could create, obviously, liability issues for the physician. It can also create patient safety issues.
Welcome to the WTW podcast, Vital Signs, Risk and Insurance for Healthcare, where we discuss the risk management and insurance trends and issues facing the U.S. healthcare industry. We'll speak with our industry experts and clients in search of ways to improve your risk and insurance vital signs.
Welcome to the WTW Vital Signs podcast program. My name is Joan Porcaro, and I'm the Senior Vice President of Risk Services for WTW Healthcare. And I'm very excited as today's podcast continues our newest series designed for physicians, providers, and medical practices. This podcast series is dedicated to helping healthcare professionals navigate the complexity of medical practice with confidence and peace of mind. In each episode, we will delve into the practical day-to-day strategies, expert insights, and real-world case studies to empower you with the knowledge and tools needed to minimize legal risks and enhance patient safety. In today's podcast, we will continue our focus on the topic of terminating the physician and patient relationship. There is certainly a variety of different ways to cover on this topic, so today's session is but one within a series on this very topic. As we know, like any relationship, the effort to maintain a therapeutic and respectful connection between providers and patients takes effort, and it takes time. And like any connection between two parties, the relationship can reach a point of disruption or challenge. Ideally, we'd like to work through the rough patches, but circumstances may reach a point where differences are just too far apart. The bond is broken and the mutual respect is lost. All efforts to resolve the matter have been exhausted. As the song goes, breaking up is hard to do. In this series, we'll delve into ethical, legal, and practical aspects, and we trust that we will offer you an opportunity for some thoughtful conversation. So first, I want to welcome our guest today. Today, we are joined by Pamela Johnson. She serves as Senior Manager, Practice Quality and Facilities at COPEC, an insurance carrier. Welcome, Pam.
Well, thank you, Joan. I'm excited to be here today.
Thank you. Also with us today is Jeanette Damask. She serves as Risk Manager at the Ophthalmic Mutual Insurance Company, also known as OMEC. Welcome, Jeanette.
Thanks, Joan. I appreciate you including me in your podcast.
All right. Well, let's go ahead and begin our conversation. So I want to throw out a little bit more about a specific topic when we're communicating the termination, to the patient. And I know this is always a challenging situation. Do we do it in person? Do we write it? But sometimes there's steps that need to be taken even before we get to that point. So let's start with Pam first. Pam, what are your thoughts about a physician practice, having a written policy and procedure for termination?
Oh, I think that's critical. That is a component that your practice definitely needs, because it will establish that you're not discriminating against any particular patient, but you're following your written policy about terminating a patient. And in that policy, which you'll want to review annually, by the way, you're going to not have language that would be considered discriminatory, and your decisions to terminate a patient would not be based on protected classes such as race, religion, sex, gender identity, disability, national origin, or age. And of course, it must align with the ADA regulations. So I recommend that you work with your staff and your providers on the policy language that you want. Here's a tip: include it in your new patient packet. and it's an opportunity when you're bringing in new patients to your practice to go over it. And also, you can review it at the same time you're reviewing a patient's medication history for the year. Is just a quick reminder of this is how our practice works with patients and how you might be terminated from the practice if needed.
Yeah, thanks, Pam. Jeanette, your thoughts?
I agree, Pam. It is really important to have a policy and procedure. And oftentimes when physicians or practices call, they struggle when they don't have a framework for how to deal with these types of things that come up. And there are different reasons for termination. Typically, they fall in three buckets, whether it's noncompliance, patient behavior, or non-payment. So it's important to have a structured approach for how to manage those issues that then could potentially turn into termination. And again, we always say it's best to rehab the situation, the relationship before termination, but ultimately you should have some kind of procedure for how to handle termination in your practice.
Yeah, thanks, Jeanette. And I'm going to throw another question your way, Jeanette.
Mm-hmm.
What's been your experience as far as the best practices for, actually communicating that decision to terminate the patient? Is it, including verbal or written? What's been your experience?
So definitely there should be a verbal discussion, and most of the time there should be a warning before the ultimate termination. It shouldn't be a surprise to a patient that they're terminated. I have had physicians call and they've just sent letters to patients, and then the patient gets this notification, has no idea why they were terminated, and that shouldn't happen. They should have a discussion, give them a chance to rehab the situation, whether they're struggling with transportation or are there issues going on at home that they need to deal with. Give them a chance, and then discuss with them what the expectations are. And if it happens again, then perhaps consider termination, but it shouldn't be a surprise. There should be some kind of discussion either with a physician or the practice administrator about the termination before the letter is sent.
So it sounds like some limit setting would be in order to explain, kind of as we say, if not this, then that. So, if you will, continue, with a certain behavior or issue, there will be situations where, a change in our relationship will happen. So really good point. Pam?
Yes, I think that I agree with what both Joan and Jeanette have said, but I'd also like to add that the verbal conversation is great and important, but we need to follow it up and follow your termination of a patient policy and give the patient a written letter as well. And I'm old-fashioned. I like to say we'll do the regular letter, the snail mail letter, and also a certified copy, because if practices rely solely on a certified letter, which many do when we receive calls on our hotline about they've terminated a patient and they followed their policies and guidelines and they sent out that certified letter, I'm going to ask everyone, when was the last time anybody that you know got great news in a certified letter? And probably never, or maybe once or twice. So many times those certified letters come back to you, and I then counsel the practice, well, the patient's still kind of in limbo. You may have had the provider or the practice administrator may have had an in-person verbal conversation, but it might have been a tense, unpleasant scenario, and the patient wasn't listening or grasping everything that was being said to them. And then, of course, they never got the written letter that was sent certified mail. So, again, I'm old-fashioned, but I say when you send out that written letter, which you need to do, send it two ways, the regular U.S. Post Office and certified mail.
Yeah, and I want to add to that. I probably take it a little bit one step further, Pam. I think folks know that they have a busy schedule and sometimes they just don't have time to go to the post office. So I know this is more expensive, but in my work in this, in the risk management world, we actually elected to send the letter via UPS with overnight mail. It is a little more expensive, but the nice thing is it's registered, and you can kind of keep track of it, and it will show up at their door. You can require a signature if you'd like, but most people are at work, so we don't want to be unreasonable, but we know that, quite frankly, no one wants to go to the post office and get in line. I mean, it's a busy time.
Oh,
So
I like that.
yeah, it's a little bit more expensive, I realize, but most practices and health systems, they usually have some kind of contract with FedEx, or even the U.S. Post Office has what is it, overnight mail, I think is the classification. So just something, food for thought, basically. Yeah, and I want to say, our work as consultants, most of us have worked on the operational side where we maybe manage a practice, or we've, been a director over a department, and the concept and topic of documentation. We're risk management people. It's always going to come up. So, I've had a couple cases where the patient-physician situation has finally reached a point of being on the last nerve, and then maybe there hasn't been, kind of the documentation we would like. So I'll start with Pam again. How important is it to document all the efforts to address patient noncompliance or behavioral issues before terminating?
Well, as difficult as that is, and as you're right, Joan, sometimes it's when that particular patient that just test your last nerve leaves, that's the last thing you want to do. And it's probably even harder to have a very objective statement about what just occurred with the patient. But the documentation at this time needs to be objective, not subjective. I like to say tell the facts, and I said this, they said this, I recommended this, they said that, whatever. But just some kind of documentation. It doesn't have to be 4 pages long, but that I would like to say, does it tell me the story of your relationship with the patient?
And Jeanette.
Yeah. And it's important, based on what the issue is. Say it is noncompliance. Sometimes there is a patient that is no showing, canceling appointments, not following recommendations. So there's steps before the termination to document that noncompliance, because that could create, obviously, liability issues for the physician. It can also create patient safety issues for the patient. So sometimes we recommend, having that noncompliance policy, and after maybe 2 or 3 no-shows, send a letter explaining this is what the expectation is. We really are concerned about your health. You need to follow our recommendations. If you don't follow, we might have to terminate you from the practice, because it can really create liability exposures for the practice. And similar patient behavior, if that's occurring and the patient is not following mutual respect in the practice, then that needs to be documented, and then also potentially followed up with a letter saying, if this happens again, we're going to have to terminate you from the practice. But I think it's really important to give them a warning before just going straight to termination, because there are so many downstream effects that can occur from a patient not having that continuity care.
Yeah, and I think it's important too that, we always say everyone's a risk manager. So, when these bad experiences or problematic behaviors happen at the front desk or even with the billing, we need to make note of those too as well, and work with those who document in the chart to make sure there's mention of it. And I think too, I think both of you called out how important it is to, be factual. You can be brief. Really, you're cataloging, kind of the history of that relationship, and any relationship, there's going to be bumpy parts, and again, making sure that there's good, consistent, commentary in there that talks about kind of the tone of the relationship, and the direction that it's going. So great comments. So thank you. So we're going to move back to Pam again. So, what are the legal, and practical steps a practice should take to ensure the termination process, is really handled properly? And we don't end up with a situation with the medical board that constitutes patient abandonment.
Oh, yes, you don't want to. That's a rough one. That's a case that's hard to defend with the medical board. So, a couple of things come to mind when I think of abandonment. You can't stop treating a patient in the middle of a post-op period. That's one of the first ones that comes to mind. We receive a lot of calls from orthopedic doctors that, there might be kind of a long post-op recovery period, and as Joan likes to say, that patient is getting on the doctor's last nerve for a myriad of reasons. And we'll receive phone calls that's it, we're done with Pam and we're getting rid of Pam. And I don't like that word either. And I'll start asking some questions, and one of the first things I'll say is, well, tell me, like, is this week 2, week 8, week 14? Like, where is this in Pam's post-op period? And I really hate to hear when it's week 1 or 2. And even I hate to hear week 12 as well. But we can't, as a provider, you cannot terminate a patient in the middle of treatment. And another example is an oncologist. They'll say a patient is undergoing chemotherapy and it's not going well, and they're non-compliant, they're no-shows, they're this, they're that. Well, stopping chemotherapy has, as Jeanette said previously, a huge downstream effect on the patient's potential outcome. So that's the time, even though you may not want to do it, is to have a conversation with the patient. And I'm going to go out on a tree branch here and say, sometimes if you have difficult patients, if you know their family dynamic at all, and if sometimes there's someone that you see that brings them, a spouse, a son or a daughter, family member, is you might bring them back into the conversation before you just said, that's it, I'm done with Pam, she's this, she's that, is to engage. And maybe the patient is having a hard time understanding all the ramifications of not coming or not being compliant. So abandonment is a very tough issue. And I think one more item that I'd like to say abandonment is if you live in a rural area, and if you are the only provider in town, we're not saying that you have to keep the patient forever, but it does become trickier, and you want to make sure that the patient, before they leave your practice, has somewhere else to go. Now, it may not be as convenient as, 5 minutes from their house in this rural community. They might have to drive 20 minutes down the road, but you would never want to discharge a patient in the middle of a post-op, or I'm giving an example of a chemotherapy.
I remember having that situation. Pam and I worked together before, and Pam trained me, and we did a risk assessment in a rural area. And there was maybe 3 obstetric providers in the area, and they wanted to terminate a patient, and 2 other providers in the area had already terminated this patient. So she's pregnant, first trimester, and then to terminate her and not have any other providers, it just wasn't recommended. So there are some sticky situations that you can get into. So really want to look at, your area that you're in, location, or are you super specialized that you might be the only physician that provides that care. So it's really important to try to focus on rehabbing the situation before terminating. And then also another issue is the managed care plans. Some of those have specific contracts that have procedures to follow before terminating a patient. So you want to make sure you look at those.
Yeah, and I want to just add in, I like the word you used, Jeanette, about rehabbing the relationship. And it is true that sometimes, if you can take a moment and really, work through whatever the issues are. I've had situations where patients have been involved with the practice for maybe a decade, and they've come in and they have been, having a negative response to something. And, the call I would get is, can we terminate? And, I often say, well, from this perspective, have you ever had any issues before? Is something changed? And, having worked in healthcare environment for a very long time, I also gently remind folks that sometimes how we behave, how our practices are maybe organized, and maybe some of our own policies kind of can frustrate people. And, we can necessarily, maybe even be at the root cause. So, if you're able to take a pause, ideally you should. Now, I always, and I'm sure my colleagues here today will also draw the line that there has been an act of violence. My rule of thumb is anytime a patient's leaving in handcuffs is a good opportunity to consider the relationship is not in good stead. And then, also important is, it might be that another provider in the practice, can work through some of those issues, or maybe that, they were working with the MD, but maybe working, with another individual like the PA, if you have one in your practice, or if you have a nurse practitioner, to just try, different personalities, just to see if there's a way to, kind of get things on a more firm, positive footing.
That's a good point. And other questions that we get involve, are you just dismissing from this one physician? Is it the whole practice? And then I've worked with a health system where is it the entire health system? So there are obviously larger ramifications if the entire health system is discharging a patient. So that just needs to be clarified.
Yeah, and obviously when we've had to do that in the past, an entire health system, obviously EMTALA still is applicable and must, still be followed. So, we want to do a good analysis. And the other thing I mention is it's really the ultimate decision of the physician or even the medical director. And I've had situations where people in different roles, like, a medical assistant, or another person in the practice has terminated the individual, and we really, again, it's ultimately, the physician who holds the responsibility and accountability for the situation. Yeah, so I'm going to bounce back to Jeanette again. How much notice should be given to a patient when ending the relationship, and what kind of resources do we want to provide them to help them as they move on into this next transition?
So standard nationally is 30 days. You certainly want to look at your state guidelines to see if there's any regulations that dictate longer time period. But as Pam had mentioned before, you also want to keep in mind, if they have a 90-day post-op period, that you're not terminating before the 90 days is up. But 30 days is standard, and you give them 30 days for emergency care and provide that care. Make sure that they're aware that they can come to you for any emergencies, so there's not that issue. Obviously, if there is a threat of violence or an actual violence that occurs, you can terminate them immediately. But, or any criminal act, that can be an immediate termination. So that's important. But, if it was just a minor issue, you can't just terminate someone without giving them the 30 days. That does lead to patient abandonment, which also can lead to board complaints and negative online reviews, because we get a lot of those kind of calls as well, where patients are blindsided. They're not given the 30 days. They've got issues that are outstanding, and then they go online and post negative reviews, or they report the physician to the board. So you want to be careful of those potential consequences.
Thanks, Jeanette. Pam, anything to add?
Well, the one topic that we haven't talked about, and I think it's really important in today's environment, is, and Joan, you're the expert in this field, can you terminate a suicidal patient? We get those calls sometimes. And what do you think, Joan?
Well, I think, with any behavioral health relationship, and that can be in a physician practice that solely is psychiatric practice in nature, or any practice, being able to make sure that you really have analyzed the situation well. You maybe have to bring in other individuals. Possibly if you're a primary care doc, you might want to bring in psychologist or some type of social service in the community if it's available. But we do have to figure out that that patient is indeed mentally stable before before termination. Now, mentally stable is a rather vague, large, way to approach this, but we really have to look at, is it indeed the behavior? Are there other ways that medication might support the patient being in a more comfortable place with interacting with others? So again, really a deeper dive. And in these situations, I often think, yes, it is ultimately the physician's decision, but it's actually a team event, where we really need to case manage and look at, different opportunities for just, a safe care transition, being able to, possibly shift care to another provider or another physician, in the community, or even another service, if possible. I mean, again, obviously, they're coming in for a medical situation. We have to take care of those particular aspects as well.
I also wanted to mention that I think maybe we talked about them, I'm not sure. And I don't know if this still happens, but back in the day, people sometimes left their prescription pads out, and it has been known to happen on more than one occasion where that prescription pad left the office. So if your patients participated in any criminal or illegal activity while they were at the office, that is also grounds for immediate termination. And of course, excellent documentation. And then sexual harassment or inappropriate behavior toward your staff. I think we're going to talk about this in a little bit, but that also is grounds for immediate termination with very objective, factual documentation of who did what to whom. Sorry to say that those two things do still occur.
Yeah, one thing to highlight, and you touched on it earlier, Pam, is it should never be discriminatory. So
right.
I recall a practice calling and saying, it's really expensive to get a sign language interpreter for patients. Can we terminate them because it's costing us a lot of money? Well, that would obviously be discriminatory. So no, you can't do that. So if there's if they're protected class, based on race, religion, gender, disability, they cannot be terminated because of those issues. That would be discriminatory.
Yeah, and both of those comments about sexual harassment of the staff by the patient, or what you just mentioned, with regard to any type of protected situation, I want to go back and ask another question. When we're thinking about staff training, how much and how deep do we go? How much does comprehensive staff training contribute to actually working through those challenging patient interactions, and how to make better, informed decisions. Let's go to Pam. What's your experience been with working with practices?
Oh, I think that is probably one of the most important things, is that your staff need to be trained on all of your policies, including terminating a patient, because when in my decades of doing risk management assessments, the first person that I see at a practice or a facility is the front office person. And I feel sorry for them many times because I think they take the brunt of unhappiness or dissatisfaction or inappropriate behavior. And so if they're not adequately trained, the first response is, of course, is to become very defensive. And then during communication workshops, that just escalates. So now we have two very defensive people kind of going at it. So I can't highlight that enough, is that is the onus of the practice to train all of their staff on de-escalation and good communication, because sooner or later somebody's going to have an unpleasant conversation with either a fellow staff member or a patient, and they need to know how to handle it.
I would definitely agree, because you want to give them the autonomy to be able to handle these situations. Staff should be trained that it's not their job to be abused in healthcare, because I oftentimes will get calls and it's been the third time that a patient has been verbally abusive to a staff member, and the staff member's never reported this to either practice administrator or physician. So it's important that if something does happen, that they do report it, so that the issue can be nipped in the bud and it can be addressed. Because the problem is when it escalates and, it happened multiple times and then nothing's done, that creates just more issues within the practice. So it's really important that they're trained, how to address the issues with patients and then report it if something does happen with a patient.
Yeah, and I'd like to add, be able to know how to escalate and who to escalate to.
Mm-hmm.
Sometimes there's, one particular person in a practice or in a hospital department that just is a little more comfortable with diffusing a situation. And it doesn't necessarily mean it might be the manager. It might be that somebody knows that patient and really, has a way to, kind of get to the root of that patient's anxiety, which is maybe causing some of that acting out, behavior. So, we mentioned a couple of things. We talked about, the sexual harassment. I've had situations where, patients have actually put hands, on doctors, staff, in the practice, in the hospital setting. So how can a practice, and we'll start with Pam again, how can the practice balance, their obligations, to the individual patient with the safety and well-being of staff, but other patients too that are in the area?
Well, I think one of the primary things is to identify what is acceptable behavior and what isn't. Verbal abuse is equally as damaging as physical abuse. And so I went to a presentation and it was like, when is enough enough? And so I think that is up to the practice to determine. I mean, there's lots of resources out there to help you, but to have very clear expectations, write them down, communicate them to both sides. So the staff and the people at the practice and as the patients as well. Like, we will all want to get along. We want to have a harmonious experience here. We want to promote patient well-being and patient safety. But we also, and I think this is sometimes where practices fall short, and it makes me really, really sad, is that sometimes we are quick to blame, like, the staff, like, well, you shouldn't have engaged, you shouldn't have done this. We know that Pam is a hothead, she has red hair, or whatever, and I've seen this conversation in break rooms or whatever. It's like, oh my God, here comes Mr. Smith. Well, we all know about Mr. Smith. But for me, as someone working at the practice, I feel like the practice is kind of endorsing Mr. Smith's behavior because we're just accepting of it. Like, we know, here comes Mr. Smith. So I know Jeanette has seen that as well. So
As have I.
Yeah, I remember seeing the signage in hospitals now where they have the patient expectations, and that not only reinforces to patients that we don't accept this behavior from patients, but it's also reinforcing the staff. Like, this isn't part of your job to be abused, and we have your back. Like, we're on your side and don't expect, you want to provide a safe working environment for your staff. And part of that is letting them know that, you're going to do something if they're being mistreated by a patient, and you'll address it.
Yeah, when you were both talking, it just brings a memory back as a former ER trauma nurse that, it was considered part of the job, and it was, considered, to be kind of the, the norm. And, there are times when patients, situations of injury and such where their ability to control their behavior is a challenge. And that's where we want staff to know how to protect themselves as best they can. But it's those other times, that, nobody gets up every morning. We always say no one gets up every morning and goes to work with the intention of hurting a patient, but they also don't have the expectation to come home after being hurt by the patient. So, we want to, kind of walk gingerly. Good points. I would say I've been seeing more signage posted, in health systems, and I have seen it in few physician practices. And the messages are essentially with the same intent, but the messages might be softened in different ways that make sense for that particular practice. So, it is something to consider, for sure, to look at that, as well. And I think I know working with my clients, one of the popular requests I get is, can you come and talk to us about complaint and grievance management? Because sometimes, patient termination, what's been at the root cause is possibly, an unresolved complaint or grievance that has happened that, again, not saying the patient's right in doing so, but sometimes, patients can get on their last nerve. They can have their own last nerve too if they feel like they're not, having the kind of engagement. So we want to kind of keep a balance with that. I want to go back to just one other question here, like, that the topic of how do we ensure continuity of care during that 30-day, transition period. Jeanette, do you want to speak about that a bit?
Yeah, so it's really important in your policy and procedure to have a form letter that you send to the patient. Like, here's how you can get your records. Here's how you can find a new provider. We do stress not to give them actual provider names, but you can go to the medical society. You can go to your health carrier. Here's your options. We will provide refills for the next 30 days, or if you're in your post-op period, we'll continue to treat you during your post-op period. But you want to make sure that all of this is outlined so that they don't slip through the cracks and that they aren't sure what to do next, but to give them the framework to follow to get their records, to get them transferred, and then have a smooth continuity of care.
Yeah, as smooth as possible. Pam, other thoughts?
No, I think that just be mindful, depending on what kind of contracts you have with your insurance companies, is to just review those before you send them all out. And I know one of the biggest beefs used to be like, I can't get my medical records. Well, now with the Cures Act, everybody can look at everything all the time, but it's still, that is so important to promote patient safety. Is I agree, I would not give someone particular names of people, because then it looks like you can be considered that you're endorsing them or whatever. It's just a generic list, like here's a list of ENTs or orthopedists or dermatologists in Dallas County, for example.
Mm-hmm. Or passing off a bad patient to another provider.
Yes.
Then I've had calls where someone said, well, I don't really like this doctor, so I'm going to give this doctor this patient. I'm like, that's not it. No, you don't need to get into that. Give them their options, the patient choice, where they want to go next.
Again, that whole aspect of trying to help, facilitate finding a new provider. I know that there's, a lot of different options out there, and obviously their health plans should be able to, help them with it. So any thoughts about that?
No, just offer that as a resource, because sometimes I think we don't think about that when we're, either having the verbal conversation and or in the termination letter. I think the termination letter just kind of spells out everything. We'll provide medications for the 30 days. And I'm kind of a stickler in our practices. We actually put in the 30-day period, like January 1st to January 31st. I think that's just a nice thing, and then it sort of cuts out the calls like, well, I didn't know when the 30 days started. Was that when?
Yeah.
When I got the letter, when you sent the letter. Yeah.
Yes.
When I received the letter.
Yes. Oh, yes. I'm sure you've all heard those. I've heard those. So I think that's why we just strenuously recommend to practices is like tighten that down, like put it right there, underline it, put it in bold, however you want.
Yeah, so unless there's an emergent reason for termination, like we've said with violence, obviously, but I always like to give them a little bit of wiggle room. So maybe I'm mailing the letter, on the first of the month, and I know it's going to take some time, or I know the patient's coming in for an appointment, and, and I want to at least have that conversation, I'll try to buffer it a little bit. But there's one topic we hadn't really touched on, and I know a lot of times I would get calls and have continued to get calls where, folks have said, the patient's not necessarily, violent, but they're just disagreeable. and how can they make sure they're protecting themselves and their staff when they're, having this conversation. This is a topic for an entirely, different podcast of, what is your emergency preparedness plan for your office? You might have, a good fire safety plan, or, you have a water main break or power goes out. But, making sure that you have, a good conversation about how you are going to address maybe the unwelcome intruder, but also the unwanted, concerning kind of upset that, puts people on edge. What's the plan if there's a concern that anxiety of the patient is now actually moved towards acting out behavior? So again, that we can do a whole webinar on, and I am available to do that. But again, it's to give a little wiggle room. I mean, if it's going to take a couple of days for you to talk to the patient and then to follow with the letter. Yes, 30 days, but it doesn't necessarily hurt if it's 35. But,
no.
You build it into the letter. We're letting
Right.
you know that effective, if this was the 24th of the month or 25th, that effective such and such, the first of the month, this is when it goes into play. So, yeah. And that leads to, for some patients, this becomes, very emotional. And are there any other tips we want to offer about, providing any practical solutions for their potential stress response? Pam?
I think everything we've said so far, but just reinforce it. Like, we're here for you. Well, if you have an emergency, you give us a call. We're not just literally kicking you to the curb tonight at 5 p.m. We're still going to be here for the next 30 days if this is a non-urgent termination. And that we'll do everything we can to help you get your records to where they need to go in a very timely manner. And I don't know if some people like to do this. I have some practice managers that are really friendly and very helpful, and they'll say, if you have any additional concerns, here's my office number and you could give me a call. I don't know if people do that anymore. That was kind of the old days. But I think most importantly, recognize that this is a stressful time for all parties involved, not just the patient and not just the provider. Because it is difficult. If you talk to providers that have to terminate patients, even those that got on their very last nerve, maybe 6 months later when I'm back at the office and I'm talking to them and they're saying, oh, I had to terminate, red-haired Mr. Smith. I don't think, it's not like they're callous and they don't feel bad. They do feel bad, but they have to look out for everybody and the best interest for everyone concerned.
Jeanette?
Yeah, and I think it goes back to what we've talked about, that it's really important. This should be as a last resort, that this shouldn't be a surprise to patients, that there should have been a warning, a discussion about behavior or noncompliance, so that they are well aware of consequences if it continues. I know I worked at a health system and they always said stress, like giving the warning, and said the majority of the time, like almost 90% of the time, once they spoke to a patient about their behavior or noncompliance, they turned around and it didn't happen again. Uh-huh. So it's really important to stress that, because oftentimes we'll get calls where they just want to terminate automatically, and instead of addressing the issue and trying to work with the patient. So again, it's going to be stressful for the patient if it comes to that.
Having those difficult conversations, you want to have the right, mindset, and you want to, make sure the right people are delivering, that message too. Pam?
I'm just sorry that it has to happen.
I think the other thing I just want to remind our listeners is, when you are writing your policies, think ahead how you're going to handle the request to have that termination appealed. A lot of times we will get the call, well, the patient's asking, for an appeal. Can they be reinstated? And, obviously, there's no blanket response to that. It's each case is very, very specific and has to be treated as such. So just something to consider. All right. Well, we are at the close of our conversation. I have to, thank you, and first both for joining in to this call. We have all had the opportunity for many, many years to work, in these settings and also in the supportive role of consultants. So I want to first, thank Pam, for joining us today. Thank you, Pam.
My fun. I was reuniting with my fellow risk managers.
Yes, indeed. This is what's the old saying? The band is back together.
Yes, the band is back together.
And Jeanette, thank you. It's really been a pleasure to connect again, and I appreciate your time with us. So thank you.
Thank you. Appreciate it, Joan.
Well, in closing, I want to thank our listening audience and those who have tuned into our discussion. I hope you'll be joining us for future discussions and our webinar series that will continue in 2026. So again, thank you for listening to our podcast, WTW Vital Signs.
Thank you for joining us for this WTW podcast featuring the latest thinking on the intersection of people, capital, and risk. WTW hopes you found the general information provided in this podcast informative and helpful. The information contained herein is not intended to constitute legal or other professional advice and should not be relied upon in lieu of consultation with your own legal advisors. In the event you would like more information regarding your insurance coverage, please do not hesitate to reach out to us. In North America, WTW offers insurance products through licensed entities, including Willis Towers Watson Northeast Incorporated in the United States and Willis Canada Incorporated in Canada.